Shubhankar, let me know when I can start, please.
Good evening, Abha ma'am.
Good evening, Nivedita.
आभा मैम इज अनदर पर्सन जिनके कॉन्सेप्ट मतलब बहुत अच्छे हैं
Monica, we can start
तो नहीं
now.
तुम खींचो।
नहीं सीरियसली मैं तो मैंने आपको पहले भी बोला है।
Let's please start so that I can welcome everybody.
Yes, ma'am. I will start my screen sharing.
A very warm welcome to all the esteemed faculty members and the delegates who have joined today from the East Zone. This is the ECHO webinar series started by none other than Dr. Kalyan Baramde sir, which is enhancing care for healthy outcomes for and improving perinatal mortality and morbidity for the mothers. And these are focused webinars for gynecologists. This is the 6th episode in line. And today we have Dr. Bhaskar Pal sir, President-elect, and Dr. Abarani Sinha madam and Praneshwari ma'am as guest of honor who will be gracing the inauguration. Can we have the slide of inauguration, please? We evoke blessings of Lord Almighty so that we can start the webinar.
Yes, ma'am.
Shubhankar?
Yes, ma'am.
Today's webinar is in association with Siliguri, Kolkata, and Bokaro societies. Yeah. The inauguration slide. Thank you, Shubhankar. It's an honor and privilege to introduce our convener for the program, Dr. Kalyan Baramde, sir. He has been recently installed as the Vice President of the IMA Maharashtra State, and he is currently the President of IAG. Sir, we welcome you to this webinar, and we request you to formally welcome the August gathering today.
Welcome everyone for this ECHO webinar series. We are here to have a knowledge sharing that is enhancing care for healthy outcomes. In each episode, we have one stalwart from India and followed by a panel in which all local societies take part. I'm really grateful today to see my mentor, Dr. Bhaskar Pal sir, Dr. Basab Mukherjee sir, Dr. Abharani Sinha ma'am, and all the stalwarts. This webinar is going to be focused on labor room emergencies. We are going to have Dr. Basab sir giving a talk on eclampsia and then followed by a labor room emergency panel taken by me, and all the stalwarts will join for that. I welcome everyone for this ECHO series, and I request Team Corona to have CV of Dr. Bhaskar Pal sir so that we can get his blessings for this webinar.
Kalyan, please, I don't need your CV and please don't introduce me.
Yes, Dr. Bhaskar Pal sir is the President-elect of FOXI, past President of IAG, and mentor to all of us. Dr. Bhaskar Pal sir, please.
Good evening, everyone. Thank you, Kalyan, the dynamic conveners for the project, Dr. Monica and Dr. Shatabdi, for inviting me here. It's an absolute pleasure to be here and among friends. My good friend, Dr. Abharani Sinha is here. Also, my classmate, Dr. Udayan Sharkar is here. My dear sister, Dr. Vaishnavi Dev-Banerjee and Dr. Asha Gupta, they are as chairpersons. The eminent speaker, Dr. Basab Mukherjee, will give the talk, followed by the panel moderated by Dr. Kalyan and with Dr. Ashish Mukherjee as expert and Ashish Mukhopadhyay as expert. And we have a host of panelists, including Nivedita and others. I'm sure that this is labor room emergencies is something that it never stops to surprise us. When you think that you know it all, you'll get into a problem where by the time you solve it, you'll think you've lost around 1 year of age. So it is always important that we keep brushing up our knowledge and our skills. I think COVID taught us that virtual medium is a great platform. But at the same time, what is important is face-to-face meetings are important. And we need to make sure that face-to-face meetings and the virtual platform, they coexist. So I take this opportunity to all the society representatives who are here to participate in a big way in FOXI activities in the year 2026. We are already in touch with you. Our team is in touch with you. But finally, uh, please, my younger brother, Dr. Kalyan Barmade, not only a very humble person, he's a very good person. He wears many hats. He's the current IAG president. He's also the vice president of IMA Maharashtra. He has been a chairperson in FOXI committee, and his important achievement is that when the government actually came up with the hysterectomy controversy, which was that the too many hysterectomies are happening in some parts of Maharashtra. I think from FOXI as well as from AMOLS, he was the person who rolled out the Save the Uterus project. And it's now been almost 6 years, and we're still running that in the name of Preserve the Uterus, and it will still run in year 2026 as well. And Kalyan will be contesting for the post of Vice President West Zone in the year 2026. My wholehearted support is with him, and I strongly recommend that all of you support him. Thank you, Kalyan, in your endeavors, and I wish that today's program to be a great success.
Thank you, Bhaskar sir, for your blessings for our webinar as well as my academic career in the future. And I'm really glad that Bhaskar sir has already announced his FOXI year and all the activities are planning. And a very important activity which he will be carrying is the Eagle project. Every aspiring gynecologist should learn endoscopy. When Bhaskar sir was the secretary of IAG, this was rolled, and it has been done in around 125 medical colleges this year, and this is going to be continued next year. Thank you, sir, for all the blessings and all the teaching to all the postgraduate teacher students, and that is going to be the future of our Indian gynecologists. Thank you, sir.
Thank you, Kalyan sir. Thank you, Bhaskar sir, for those encouraging words. We will move on with our program. I would now like to invite our guest of honors for today, Dr. Abharani Sinha ma'am and Dr. Praneshwari Devi ma'am. Yeah, can I have the CV slide, please? Yeah.
It's okay. I don't think we need our CVs.
Ma'am, let her talk for 1 minute.
Yes, ma'am. Yes, ma'am. It's a pleasure to talk about you, ma'am. I welcome Dr. Abharani ma'am as our guest of honor for today's session. Ma'am is the professor and HOD at SKMC Muzaffarpur, as well as the National Treasurer for ISOPAR and ICOG Governing Council member, and she has been the president of the Patna Obs-Gynae Society. We welcome you, ma'am. We would like to hear some words of encouragement from you, ma'am, about today's program.
This is one of my old CVs. At present, I am Vice President-elect for 2026.
Yes, ma'am. Yes, ma'am.
And I need support from all of you. So, for all the activities which our President Bhaskar Pal has planned. So, well, thank you so much, Kalyan, for involving me in this program as guest of honor. And I know Kalyan since a long time, and he's very dynamic, and he has done a lot of work for endoscopy. And to see him in this role, that organizing an eco webinar with two very important subjects, two common subjects, but very important. And we really need to save our mothers. I think both the discussions, they will help all the participants who will be joining here. My best wishes to him for his future endeavors. And the two conveners, both Monica and Shatabdi, I think they have been coordinating very well for this program. And we have a prolific speaker, a dear friend, Bashur. I think he'll be speaking all about eclampsia with chairpersons Dr. Udayan Sarkar, Dr. Moushami Dey, and Dr. Asha Gupta joining for that. And we have all the friends from our three societies, that is Kolkata, Siliguri, and Bokaro, who will be participating in a very important panel discussion, that is labor room emergencies, where always surprises come for us. So this will be moderated by Dr. Kalyan Barmade, and the expert is none other than Dr. Ashish Mukhopadhyay, and my dear friends from Bokaro, Dr. Nivedita and Dr. Rupam, and I think Varuna, and Dr. Sindhu, again, she has been my student in my residency days from Siliguri, and Dr. Pranomita Ghosh, and Dr. Anupriya Pankaj from Bokaro, and Dr. Chayan. So it's really nice to see all of you participating in a very important discussion. And of course, I also take this opportunity to pay my regards to the chief guest, Dr. Bhaskar, and my guest of honor along with me, Dr. Praneshwari Devi Madam. So thank you once again for involving me in this wonderful webinar as guest of honor. I'm really grateful. Thank you so much.
Thank you, ma'am. So nice to see you.
Very nice to see you.
Thank you, ma'am, for your words of wisdom and blessings, and all the best to your career as a vice president, which will be starting from January. We are seeing to it that so many activities and so many people from East will involve in these activities, ma'am. Thank you so much.
Thank you.
All the best, ma'am.
All the
Thank
best.
you. Thank you.
Thank you, ma'am. Thank you for those words, ma'am. Really great to hear you, ma'am. I think Praneshwari, ma'am, was having some issues in joining, sir. Should we proceed with the talk then? When
We'll
ma'am
start.
joins, we can take.
Yes, her blessing afterwards. Yeah.
Yeah, because she was having some issues in the network. Okay, so we'll move on to our session. Our first session, we have a very important talk to be given by none other than Dr. Basab Mukherjee, sir, on all about management of eclampsia. We have three eminent chairpersons with us, Dr. Udayan, sir, Dr. Asha Gupta, ma'am, and Dr. Moushami De Banerjee, each from the societies that we are doing the program today with. So please, can I have the CVs, please? Dr. Udayan sir is a professor and in the Department of Obs-Gynae at MGM Medical College, Kishanganj. He is the secretary of our Siliguri Obs-Gynae Society and a very, very young and active member of our society, if I may say so. Welcome, Udayan sir.
Welcome, sir.
Thank you. Thank you, Dr. Kalyan. Thank you, Shatabdi.
Thank you, sir.
Our next chairperson for the session is Dr. Asha Gupta, ma'am. Ma'am is practicing Obs gynecologist at Jamshedpur. She is in charge of the Cultural and Media Committee of JOGS as well as an active member of FOXY, and she has been the national trainer for violence against women, which is a FOXY and UNICEF collaboration. Welcome, Asha, ma'am.
Thank you
our
very
next chairperson,
Welcome, ma'am.
Dr. Moushami De Banerjee, ma'am, from Kolkata. Ma'am current at Kolkata as president of BOGS as well as the past vice president of IMA Calcutta branch. She also has been the chairperson of the reception committee during the BOGS conclave in 2024. Welcome, Moushami, ma'am.
Welcome, ma'am.
I would now request Moushami De ma'am to kindly introduce Basab sir, and then we can proceed with the session. Can I have the CV of Basab sir? Yeah, thank you.
At the beginning, I must thank Dr. Kalyan sir and Monica and Shatabdi for making me a part of this program. And it's a proud privilege to introduce Basho. BOGS is very proud of its presence. And he is the vice president of FOXY. He held in 2020-23 and member FIGO Safe Abortion Committee. Then he's the immediate past president of the Bengal Obs-Gynae Society, then the secretary of IIG Bengal chapter last year. And he has many awards, and he also has he's a very good leader and an organization role in various conferences. Waiting to hear you, Basho, and especially so proud of Bhashkarda and Basho from our society, really.
Thank you very much. Thank you very much. So,
welcome, Basab sir. I'll just tell you one thing.
Yeah.
He has a more fan following in Maharashtra than Kolkata. So he's a person of great heart and a dear person to all of us. And welcome, sir, for this webinar.
So just 1 point from my side too. I had the pleasure and the honor of working with Kalyan when he was the chair of the Public Awareness Committee. I was 1 year as a vice president with his committee, and it was absolutely wonderful working with him. He's an active worker, and his work has been seen in IIG. He heads the national body in IIG, and I wish him the best along with everybody else for his future role in FOXY, which is very forthcoming. And I'm sure that he'll do as good as he's done ever. So just to, I have to share my slides. Just a minute. Just give me a second, please. So is it visible? Just tell me, please. Can you see?
Sir.
Yeah, can you
Yes,
see?
sir.
Yeah, thank you. Thank you. So thank you, Kalyan. Thank you, Shatabdi. It's good to see Shatabdi in a gradually increasing national role. We'll need to see more of her in the days to come. Monica is already in the Foxy forefront, but Shatabdi we're waiting for. I thank Priyankur actually in absentia for getting both of them deeply into Foxy, and I'm sure that in years to come, Monica in her present role and in her future role and Shatabdi will come into the national fold and make us all proud. Thank you for inviting me, and this is something different. After a long time, we're talking about eclampsia. Managing eclampsia classically would be something like postgraduate teaching, but I tried to make it a little different. And over the next 12 to 15 minutes, let's talk to something about eclampsia, and we're happy to have some discussion at the end of it. So no queries, but discussion. People can share things which they have done or what they have seen in the future. So maternal mortality rate and eclampsia. We understand a significant cause of maternal mortality in India is eclampsia and hypertensive diseases, with specific figures of how much it affects maternal mortality varies from by study and by region. The contributing factors include a lack of regular antenatal care, lower socioeconomic status, young primees are the people who we see having more of eclampsia. The most frequent complication leading to death is the pulmonary edema, and others being HELLP, stroke, and acute renal failure. We see ARF quite commonly in a case of eclampsia and severe hypertension. So this comes from the National Rural Health Mission, NRHM in India. If you want one page in which the management of eclampsia is there and something from India, this is the page you should be looking at. And here it's got everything which is summarized in a one-pager, mainly targeted towards primary healthcare centers and community centers where eclampsia is essentially managed more than in tertiary centers, because still we see it comes out of the blue. Yeah, of course, with more awareness and more education, it is less than what it used to be before, because there's more antenatal checkups, more supervision during pregnancy in the present era, which was less in something 2 to 3 decades ago. So the last 2 to 3 decades ago, the eclampsia wards would be full, 6 to 8 patients we used to see at any point of time. Now they're much less, but it's still they are there, and there are deaths happening due to eclampsia all over the country, which we can always prevent. So the idea generally would be the same. There would be at least 3 points of approach. One would be to tackle her during the time of seizures, immediate resuscitation. That would be point 1. Point 2 would be to keep the blood pressure down, the antihypertensives which we can use in that point if she's already admitted, which she would be. Number 3 would be the magnesium sulfate, some discussion on that lines. And number 4, if it is antepartum eclampsia or intrapartum, how fast we can deliver her, because delivery is, after all, the action or the intervention which will help in controlling the problems. So these are some things which are the basic idea of eclampsia, and the possible warning signs of eclampsia, which comes from Cleveland Clinic, which I'm sure would be seeing much less of eclampsia than what we see in India. But they have come up with a pictorial chart where they're causing severe headaches, difficulty breathing, nausea, vomiting, trouble peeing, abdominal pain, blurred vision, swelling of hands, face, or ankles. All these are signs of severe hypertensive disorders, and in some cases, eclampsia. So the resuscitation protocol, let us go a little bit through that and see what has changed and what is new. So you look at the dangers across, look for the response, always shout for help or send for help. Airway, breathing, compression, and defibrillation. There's some change to the ABC, which we knew. We'll just come to that in a minute. But if you happen to see a person during an eclamptic seizure, what should you do and what should you not do is some practical points, which I think some of us know, some of us need to know. First of all, during the seizure, if she is having a convulsion, try to stay calm, keep others calm. I think that's important. Most seizures are brief. It'll stop in 45 seconds, 1 minute at most, 1.5 minutes. Protect the person from injury. If there's something which is around her which she can hit, then you try to remove the hard and sharp objects. Trying to get her on the ground is obviously the normal thing. She would already be in the ground, sometimes in the fetal position when she having the convulsions. Gently place something like a folded jacket under her head till it gets over. Loose any tight clothing around the neck. Try not to hold the person down or stop their movements. Usually we have a tendency to hold her and make sure that just to press her to that it stops, but that should not be done. This can cause injury. Do not put anything into the mouth. There was one point of time where you put a spoon in the mouth or something in the mouth so she doesn't bite her tongue or bite off her tongue, but that doesn't seem to be working. So don't put anything into the mouth, including water, medicine, and this can cause choking and damage to the teeth or jaw. So what happens after the seizure? Just after the seizure is over, gently roll the person on the side, which is the recovery position. This allows any saliva or vomit to drain out, keep the airway clear so he doesn't aspirate. So that's a normal thing which we do. In a Western country, you would check for a medical ID bracelet, something which you'd note that if she has a case of eclampsia, she may carry a card or some identification which would know that she's an existing case of epilepsy where she is on a medicine which she may have forgotten, which needs to be given. Time the seizure if possible when it was for medical legal purposes or for even writing it down. In a pregnant patient, of course, this does not matter. Call for emergency help immediately just after it is over. And especially if it's a person's first seizure, which you may not know, and if it lasts for a very long time, then she would definitely have some problems immediately after, which would be confusion and also difficulty in breathing. And once you can, she's regained her consciousness, you can reassure and comfort her. What about her airway, breathing, and circulation? Well, there is a question about ABC. It's changed from what it used to be before, but generally the idea would be check for responsiveness. That is, of course, after the seizure is over. If she is responsive, she is all right, then it's fine. But anyway, you call for help because you need help besides the help which is there. This comes from the European Resuscitation Council. Open the airway, absent or abnormal beating, start CPR. So now the general idea is start chest compressions immediately. Don't go for the mouth-to-mouth resuscitation. That is in the past. So main idea is chest compressions and good chest compressions that you really press the sternum by at least 2 inches. So you have to be in the right position. You have to have a hard surface below and start CPR as soon as possible. If you are trained in doing the basic life support, you can have 30 presses and then 2 breaths. But otherwise, you can do pressing chest compression alone. That's fine. An automatic external defibrillator, if you have that, all is fine, but often we do not have it. So you continue CPR until the emergency medical services arrive or till she is already conscious and she's getting a pulse and she's breathing. So these are some things which are there, which are important in the things. So once she is up, when she is active, once she is fine, the other thing would be, besides among other things, is to establish a diagnosis to know what level of whether she has help or not and what the thing is. Of course, by that time you would have been checking the vitals, you would have been checking her pulse, her blood pressure, her respiration, saturation. By the time if she would be we would have got her to a medical center, and you would have also maybe put her a catheter in also, because you would need to check for urine output also later. So then when you're starting an IV line, for giving Magself, you also would need to take blood when you are starting the IV line. It makes common sense that when you start the IV line, you collect the blood and you take it for all the things which are written here: full blood count, platelets, because you're looking for help, and also you're looking for elevated liver enzymes to OTPT there. And of course, you could be looking at some already damage for the liver. So a full LFT would be going out there. LDH should be going down with some evidence of hemolysis out there. And then you'll be looking at fibrogens, FDP, and your PT, APTT, because if it's a liver injury or if it's there for some time, that would be deranged. And then you would look at the kidney function tests. Uric acid, not so much preferred. 24-hour urine collection, not so much preferred now, but a basic urea, creatinine are also some idea which you would get. The next line of an eclampsia generally be managing the hypertension. So all these things, as we know, in a true life, they happen all together. It's not in isolation, because in PowerPoint, you have to show one slide after the other. You break them into parts, but as I said in the beginning, you have 4 interventions. One is to stabilize the patient, of course. One is to control the hypertension if she is hypertensive, which is there in 90% of the cases. 10% may not have hypertension. Next is your magnesium sulfate. Even default, even if you don't know she's epileptic, you would first give the loading dose and then you will try to see the records because you may not have much time. And then is the delivery in case of an antepartum setting because you need to deliver the baby. Of course, before delivery, you'll have a fetal surveillance and see what the situation is like. But if you have time to wait and the cervix is favorable, you may try induction, but most of the times you would go for a planned section in most of the times. So treatment of hypertension, well, systolic blood pressure more than 160, diastolic more than 110. The idea to be reduce it to maybe 90 to 100 is okay, 80 to 90. Possibly in a classical setting, you would like to keep it around 90 to 95 possibly. And even the systolic around 150 would generally be acceptable. Avoid maternal hypotension and monitor fetal heart rate with continuous CTG would be generally what all of us would do. Depending on the prematurity or how early it is, the CTG may not be very easy to interpret if it's 32 weeks, 33 weeks. But if it's closer to term, you'll have a fair idea. And if you have some good variability and accelerations, you'll at least be happy that you have some time in hand for dealing around with the baby or delivery till you get the mother stabilized. So antihypertensive drug, depending on what you have, nifedipine is one of the ones which you can give orally if she is conscious and she can swallow and everything is fine. But hydralazine is often preferred if there's a place where you can give hydralazine, but sometimes it has a rapid hypotension. So you need to be careful. You need to know how to use the drug. 5 to 10 mg IV over 3 to 10 minutes. And repeated doses sometimes may be required. Infusion may be required. And labetalol is also frequently used. Now, labetalol we use extensively as a tablets, but you can also use an IV. Sometimes people like to give it in a critical care setting, but whatever setting you would have, an IV bolus of labetalol would help to bring the blood pressure down if it is very severe and high. The reason why you want to bring high blood pressure down is you want to avoid a stroke, you want to avoid acute renal failure, you want to avoid a cardiac arrest. So all these things are for if it's a 200 over 160 or 210 over 140, then obviously you run the risk of all these problems for which you need to get your blood pressure down and quite fast. But if there's a living baby inside, you have to be careful of that too, and you have to also monitor, and that has to be in the time. Labetalol infusion may be required where you're giving a small dose continuously, and that keeps the blood pressure under control. Shifting from the antihypertensive part to the magnesium sulfate part. So magnesium sulfate for eclampsia is what we have been grown up to. So since your undergraduate and postgraduate days, we know eclampsia is equal to magnesium sulfate. 1995 was a collaborative eclampsia trial. And from there is a stamp that eclampsia means MagSulf. Before that, there was a Lytic cocktail, there was Menon's regime, and there were a lot of other things, historical ring, which makes good data for a quiz, but doesn't make a good use unless you don't have MagSulf, which is now rare because almost everywhere there is MagSulf available. How much to give, how to measure, how to prevent toxicity, that's always a challenge in magnesium sulfate, and always to remember how much exactly to add. So 4 grams or 8 ml of 50% magnesium sulfate added to 12 ml of sterile water or normal saline makes it a 20% solution, which you have to administer over 5 to 20 minutes. So there was a time in undergraduate, postgraduate, where we used to sit down next to the patient and give it very, very slowly. That still happens in many cases, but there are other cases where you can put it in an infusion drip and allow it to go. And most of the times nowadays, we would possibly do that. Ready-made solutions are available. If you have problems with the calculation, there are companies who have come up with IV magnesium sulfate, where you can just give it immediately. You don't have to do the calculation and do the mixing. They've done it for you. For some data, 1 gram of magnesium is equal to 8.2 milliequivalents. Calcium gluconate, 1 gram IV over 3 minutes is case of magnesium toxicity. We know when you're giving magnesium, you obviously have to check for the reflexes, for the respiratory rate and the urine output, mainly the reflexes, because that's what usually goes first. So the loading dose of MagSulf, 4 grams IV over 20 minutes via controlled infusion would be the most ideal thing to do. And if seizures are still going on when you're giving MagSulf, you would have to top it up with diazepam and other things if it's going while preparing MagSulf. And maintenance dose is 1 gram per hour IV. That would be the Zuspan regime. And for the Pritchard, of course, you would be giving an intermittent 5 grams every 6 hourly. So the seizures recur while receiving MagSelf, then you may give 2 grams over 5 minutes, maybe repeated after 2 minutes, or you have the other options to be given. And if there's impaired renal function, which you will not know in the beginning, but if you have your tests done after your loading dose, then your maintenance dose would not be 1 gram per hour. It would be half of that, which would be 0.5 gram per hour. And you would be considering monitoring of magnesium levels, which normally we do not, because we go by our patellar reflex and respiratory rate and everything. Checking it hourly or 3 hourly, or at least before giving the next dose of MagSelf, would be important if you're using the Pritchard regime. If you're using the Zuspan regime, then obviously you have to check and make sure that the drip doesn't run in and she doesn't become toxic suddenly for the magnesium. So we have hardly seen it in our clinical practice. Most of the times we play it on the lower side, but you have to check for patellar reflexes, because if you are not careful, then you can have problems with respiratory distress and later. Temperature, second hourly, continuous CTG monitoring, measuring urine outputs via indwelling catheter is something which most of us would do. Strict fluid balance, because as we said in the beginning, pulmonary edema is a dangerous thing which can happen, so that has to be there. Magnesium levels generally are not checked in most of the cases because you don't have the lab to check it. And even if you have the value to check it, it may not come, the results may not come that fast, because you really need to manage it quite good. The therapeutic levels we are talking about is 1.7 to 3.5 millimoles, or if we call it equivalence, it's around 4 to 6 milliequivalents per ml. So stop infusion if the urine output is less, deep tendon reflexes are absent, and respiratory rates are less. These we know. And antidote is 10% of calcium gluconate, 10 ml IV over 5 minutes, which needs to be given. So these are the regimes which are normally looked at. Zuspan and the Pritchard. Zuspan, is an IV continuous. The same regime which we also use for neuroprotection when you're talking about preterm birth, where around 27 to 32 week babies, when you have to deliver them or you have a issue, then definitely you would like to give a Zuspan regime, one course of 24 hours before the delivery, besides the steroids, because that is something which was shown to be helpful in a neuroprotection for preterm babies. Here, this is a different, but this is the same regime used in the eclamptic fits. And the last, so 1 gram per hour continuous IV for 24 hours after the last seizure of delivery. And the Pritchard regime, as we used to give in our practice once upon a time in our medical school, 4 grams per IV, every 5 minutes plus 10 grams IM, 5 grams in each buttock with lignocaine. So with lignocaine, sometimes they used to use, but we used to remember those magnesium abscesses that they used to have because of MagSelf. So this is, then there are several alternate regimes which we have heard out over time. And the alternate regimes have shorter maintenance regimes, that instead of 24 hours, 12 hours, and also reducing. And so that's one of the, just a minute. Yeah, so alternate regimes have tried to find out lower total doses. So you're giving less amount of magnesium sulfate, shorter durations where you are decreasing the amount of maintenance dose from 24 to 12 hours, and different administrative routes, and especially looking at cost, ease of use, and making sure less toxicity and patient body weight. So this is a shorter dose of 12-hour maintenance versus a 24-hour. Current evidence shows no significant difference or side effects compared to the 24 hours. If it's no significant difference, you can really stop after 12 hours, but it hasn't come into recommendations so far. And then is the loading dose only. You don't give maintenance at all. So you give 4 grams IV plus 10 grams IM, that is your Pritchard, and then stop. No subsequent maintenance dose. May be effective, but evidence quality is slow. More research is required. And the Solapur or low dose regime, where a lower body mass indices, in case of Indian women, done in Solapur, 4 gram IV followed by 2 gram IM instead of 5 gram every 3 hours. 3 hours, that's what they have showing, and they are comparing everything. Then the weight-based regimes for specific population, obese women, higher doses, less low BMI women, less doses. And that's a 6 gram IV loading dose followed by 2 gram IV maintenance per hour. That's quite higher compared to other things. And this is, again, you would need to check your magnesium levels. So alternative magnesium regimens for women with preeclampsia and eclampsia, what do you get from Cochrane? This is 2023 Cochrane. Despite the number of trials evaluating various magnesium results, there's still no compelling evidence that one particular regime is more effective than another. So still you can do a lot of things. The last few slides, Eden's criteria for risk assessment can help the clinician to assess the risks in patients with eclampsia. So the longer the interval before from the fit till starting of treatment, antepartum eclampsia, more than 10 fits, coma in between fits, temperature, pulse rate more than 120, BP more than 200 to start with, oliguria, proteinuria, some jaundice, and not responsive to treatment, all is bad. Then comes the delivery. Of course, you have to delivery. Multidisciplinary approach comes into the picture. You have to bring different people into the picture, especially the anesthetist and the intensivist, depending on what is there, and the neonatologist. Mode of delivery will depend, and actively manage the third stage. Do not use ergometrin, and consider carbetocin and venous embolism protection has to be thought about. So well-equipped room, oxygen supply, all that is there. So long-term consequences of eclampsia, this is something which wasn't so much prominent 20 years ago. But now over the years, with a lot of research, we know that women who have eclampsia in their pregnancy, over their life can have, are prone to develop cardiovascular and cerebrovascular complications more than women who do not have eclampsia or a hypertensive disorder of pregnancy. So this also is valid for severe preeclampsia also, where women may have high blood pressure later in life, cardiac disease, stroke, kidney, liver damage, and CNS damage, depending on how much of damage was happened during the primary episode. It can also have mental health consequences later. So the takeaway, eclampsia, though reduced from before what we used to see a couple of decades ago, still remains a major cause of maternal mortality in India, and we are committed to take care of that, make sure that in our capacity we can do what we can, both in an individual level and as the organization level. Universal use of magnesium sulfate is more or less there, but still there are knowledge gaps, and some people who have reservations about magnesium sulfate, which is unfortunate because it's been almost 30 years since it's been stamped as the drug of choice. So before referral and institution-based management protocols help in reducing morbidity and mortality, most of the cases we will have MagSulf. 9 out of 10 maybe now, but maybe 1 out of 10 may miss out, and that may be the mortality we look at. Resuscitation, antihypertensive, magnesium sulfate delivery are all the cornerstones of management, which most of us know about, and this was a chance to refresh it. Ideally, drills are the very easy to say, difficult to do because we are possibly lazy and not as disciplined. But unless you have drills of eclampsia in a labor room setting, we will never get it right when the actual problem comes. So I think in teaching institutes, especially medical colleges, many of drills are held in different labor ward emergencies. I'm sure they'll be taken up by Kalyan in his next panel there, and that's something which is which would be the need of the hour. Beware of the long-term consequences, have prudent follow-up, and talk to the woman and tell her that this is an issue. Thank you very much. I stop sharing.
Thank you, Basab sir. That was a wonderful lecture. Would request Asha Gupta madam and Udayan Sarkar sir to kindly give their opinion on the talk, please.
Hello.
Thank you very much, Dr. Basam sir, because your talk was so enlightening. In short, your slides were excellent, and you have given the latest update. I think it was a very knowledge update, and think the problem continues when we were doing labor room, and it continues. So I was also thinking, why don't we make some protocol in the labor room and put it the chart and everything like that, what is the first line of treatment? Because drill in another, but it should be there.
Most of the times, I think most of the labor rooms have it, but it's not implemented. When people, it may be they are gathering some dust in the corner of one part, and it may have just worn out that paper. It's there in most of the labor rooms. I think now Ashish will agree. I think most of the medical colleges will have that paper somewhere in labor room, but when the time comes, nobody really sees that and does it. I think.
Sir, in Maharashtra, we are doing Foxy Manyata training for private hospitals, and it has taken a very good course, and we are doing it routinely. And after 3 years now, we have done the second inspection, and we are passing that inspection also. The best thing about is that they ask all questions to the staff nurses. They don't involve doctors at all. So they are involving the staff nurses. So it's going to be really good for them to learn, and they give a scoring system also. And that's going to be a really good thing if you implement in each city about the Foxy Manyata project. That's what Dr. Nivedita madam wanted to talk. Can you just unmute yourself, ma'am? Yeah.
Yeah, good evening, everyone. Yeah, Dr. Kalyan, absolutely. But there's one slight point which I would like to point out, and that is it is not just for the paramedics. We are mainly training the paramedics, but as I always say, obstetrics is a team management. And the team leader is a doctor because the buck stops here. So the doctor is equally involved, has to be equally involved in the Manita trainings. The unfortunate part is the doctors do not come on board most of the time, but I have seen wherever doctors are on board, the facility performs very well. And where the doctors are not on the board, when we reassess them after say 3 years or 5 years, they tend to lose out. So it's imperative that I think Manita training is very important, and the doctor should always be on board.
Ma'am, I like to update from Maharashtra. Says Chief Minister of Maharashtra.
Absolutely,
Has
Dr.
taken a cognizance of this,
Yeah.
and 2 days back he has a big conference, a press conference, where he has emphasized all to get Foxy Manyata training.
Absolutely. He had says that a Lakshya Manyata certification is mandatory for Clinical Establishment Act in Maharashtra. Absolutely. Fantastic news.
Thank you, ma'am.
That is fantastic.
Udayan sir would like to have your comments as well.
Yes, I would like to stress, in spite of all these programs, I have still seen patients in eclampsia being referred without Maxalf, especially the senior or older generation doctors, they still have the habit of giving some sedative or diazepam or whatever. We still, get patients receiving these without Maxalf. I would like to stress that Maxalf is the drug, and we should fear about it. I've still seen the fear in certain doctors giving Maxalf who are not used to it. And especially we have not discussed about the postpartum cases also. We get postpartum eclampsia also. So whenever a patient, either antenatal or just postpartum, comes with fits, that is the first drug that we should give. And definitely it involves the team management.
Yes.
Thank you.
It is
Thank you.
entirely a team management. Yes.
Yes, we need more awareness and more eclampsia drills and involvement in the Manvata project. Yeah, thank you, Bashab, always.
Yeah, Ashita has a point. Dr. Ashish Mukhopadhyay.
Yes, Ashish.
If chairpersons allow,
Yes,
and I can make 1 or 2 comments. I'm sitting in one of the medical colleges where those charts of eclampsia are gathering dust. And very true, Bashab, I agree with you. That is basically because the government of India and also our state, they moved out of the emergency obstetric care protocols.
That is true.
So that is the point at which the U-turn happened. And, lots of, theories came out about this. And then, of course, there are the regimens about using low-dose magnesium sulfate, etc., etc. So that was the reason why I think that the eclampsia didn't get as much as popularity as PPH got. So that is my observation. Yeah. Over the years, I have seen that. Although eclampsia deserves much more. But fortunately, this incidence, prevalence of eclampsia, I think it has reduced, it's come down. In our student days, we remember that whenever we used to enter the obstetric ward, on the left side, we used to see 4 cases of eclampsia, and on the right side, we used to get 5 cases of septic abortion. The picture has completely reversed these days. You all of you must experience this. We at medical colleges, when we are giving routine rounds, we don't get to see all these things now.
So what do you see on the right side and the left side now?
Right side.
Variance.
As eclampsia is in the closer to my heart, that's why we kept them on the left side, and septic abortion was kept on the right side. You can reverse the order, no problem. And I just want to mention 1 or 2 things about the Bashab's excellent talk, as usual. The blood pressure level is very true that 160 by 110 is the blood pressure. But in many cases, some of the not moderate number of cases nowadays we see with a lower level of blood pressure, eclampsia is happening. So you call it an atypical eclampsia, or you call it early onset eclampsia, whatever it is, I think the number is increasing. So you need to be careful that 140 by 90 is the level at which we start the antihypertensive. So gone are those days when we used to start it at 160 by 110. ACOG still believes in that, but I think the world is gradually coming to a consensus that it should be started at a much lower level. And many studies have gone. My own PG has done the thesis, And we have got the Leona Poon's famous publication on that. So I think the time has come that we should decide the hypertension level at which you start the hypertension. And even it can be started just before you take the blood and go for the investigation. That's what I wanted to make. And I wish, yes, eclampsia be given much more priority. With the able leadership of Kalyan, I think it will be
That is true.
alive. Thank you, Kalyan, for inviting us in this.
And meanwhile, I think Monica finished her episode.
Yes, sir. I have. Sir, I would also like to add that I come from Sholapur, where Dr. Suman Sardesai Madam has advocated the low dose regime because it comes from the Solapur city, and because here the BD workers and the other people are very low build, so the dose of magnesium sulfate could be reduced depending upon the weight of the patient. This is what her study had said, and it is widely accepted. So most of us use the low dose regime also, sir.
Yeah, Nivedita, come in.
I just want for all seniors for this question. See, now with the Pritchard regime, the loading dose is 14 grams. But now when we have the Zuspan regime coming up, the loading dose is only 4 grams given over 20 minutes in that 100 ml NS, which is a 20% solution. And then we are giving 1 gram every hour. That means that 100 ml is given every 4 hours, because it's got 4 grams in it. So the loading dose has come down from 14 grams in a Pritchard regime to only 4 grams in a Zuspan regime. Now, I would like to ask, because even with Zuspan regime, I've not found any recurrence of fits. So as Dr. Monica just said about lowering the dose of magnesium sulfate with lower dose protocols. So if we could move from 14 to 4, I think we really need to have a, like Ashish Da is in a medical college. So if we could have a better database about whether this 4 grams is sufficient for prevention of eclampsia.
So just
Management of eclampsia.
Well, just comment. So alternate regimes of magnesium sulfate in the Cochrane database was first discussed in 2011. And that was the first Cochrane review which came. And then they said that more studies are required. We don't have much evidence on that. In 23, in the revision, which I said, the tone is softer, but still again, it's not big enough to bring into guidelines. So they said that, yes, we have some studies, but more RCTs, more things. So Nivedita, that is the basic thing where you stand, that as Monica said, that there are a lot of individual or smaller references. They haven't been transferred into guidelines or recommendations yet. But the search is on, and a lot of us are using lower doses in our clinical practice, I'm sure.
So if we stop the IM dose, because IM is painful, why don't we simply shift over to the IV dose?
That I think most of us have generally done, because in a private setup, first of all, you don't get much of eclampsia. But even in the public, what is most convenient is the IV. No? The IM is painful.
Absolutely.
The IM has
It's
things.
very painful.
I think that way we have most of us have shifted. Yes, Dr. Asha.
I have a counter argument and also respond to Nivedita's query. You see, you said that the loading dose is 14 versus 4. It's not exactly so. 4 gram is the loading dose in both the regimes. The 5 gram doses are given in the IM regime. They gradually build up in the body. While IV, it goes at a fixed rate, 1 gram per hour, whereas in intramuscular doses, they act as storehouse of magnesium sulfate, and they take time to act. Considering the safety of intramuscular administration, it was proposed, I think. That is the original regime from Pritchard.
Pritchard regime.
And another important thing I'd like to comment, that you see, intravenous is quite risky in eclampsia. Why, I'll tell you. There is a gross endovascular damage. The basic etiopathogenesis is that the gross capillary leakage happens in almost all the blood vessels inside the body, particularly the uteroplacental bed, that we all know. That's the basic pathogenesis. Now, considering that, RCOG has recently recommended the fluid rate of crystalloids from 80 ml per hour to 60 ml per hour. Why? Now, when you start giving, or rather universally practice this intravenous regime, every apprehension is that the nursing staff runs it very slowly, and pulmonary edema is a very lethal problem in eclampsia. And all the fluid that we're administering, they go into third space. They never enter into the vascular space. So that's a major danger of giving any IV infusion, or rather routinely recommending this for all patients will be quite risky, and it will be counterproductive. That is my apprehension. Recently, Bhaskar has constituted a group who is looking after the HDP management. I'm a part of that, and lucky to be part of that. Yesterday only we had a meeting and we were discussing about the reducing the fluid load inside the body.
Yeah.
And in the gestosis guidelines that we have formulated, it has been written that the preferred route is intramuscular. And we have agreed with all of them.
And one new thing also has come, Ashish, I think postpartum use of use of diuretics.
Yeah.
In case of I think postpartum use of diuretics.
I think
routine.
about diuretics, one thing is there, you never use it before the delivery, but liberally use it after delivery. I think if that we can spread many of the problems.
Yeah, never
Okay,
before
because
delivery.
we used to read it only use laxatives. Only use diuretics if pulmonary edema, if you have symptoms of pulmonary edema,
that you will
symptoms
do.
or
That
signs
you
of.
do. That we do.
Sir, maybe because these patients in rural India cannot be managed with the infusion pump, IV was not preferred route and IM was a preferred route, and it has, as Professor Ashish sir has told, the other consequences of IV also. So that is the Dr. Nivedita, that's why IM is more popular, though it is slightly painful, and it becomes like a reserve, and slow absorption will happen for that. Secondly, Professor Ashish sir, my observation in last 5 years, with the use of tablet labetalol, the incidence of eclampsia has come down a lot. What is your experience about this, sir?
Yes, that's a very good point raised by Kalyan. Thank you very much. See, as I said, the antihypertensive category B drug, all of us know, all antihypertensive used in pregnancy category B drug. But starting the dosage, the antihypertensive was a bit later in preeclampsia. I have observed our professor like Game Goon and Nagendra, they used to vehemently argue that do not give antihypertensive at 140/90. So I had an argument with them at that point in time, long ago. But eventually that has come into the recommendation. So if you start measuring the blood pressure early in the pregnancy from first trimester and gradually follow one of the screening tools. You see, whatever screening tools we have today, we haven't discussed it today, but they are not very effective in early pregnancy. But the only effective tool is perhaps the monitoring of the blood pressure level. So encourage our patients to buy a blood pressure machine, because now we use the same blood pressure machine. We cannot use mercury sphygmomanometer anymore. So we have to use the digital machines. So let the patient also have that. So SMBP is gradually coming up, self-monitoring of blood pressure from the first trimester to avoid the white collar hypertension. Whenever you see the doctor, the blood pressure rises. So at home, you can measure the blood pressure relaxedly and you can have a proper picture. And then you compare the rise of blood pressure and start antihypertensive at a lower dose. I think these are the points which can be easily taken up in our clinical practice. We are doing that at present.
Thank you, sir.
Thank you, Kalyan. Thank you.
Thank you, sir. It was a really nice interactive lecture, and everybody, because they are managing eclampsia in day-to-day life, everybody was so keen to listen to you. What are the recent guidelines, how to go about this? Maybe one parameter which sir has just pointed out about the screening. What is the role of color Doppler at 18 to 20 weeks of gestation for the high resistance flow in uterine arteries? You believe in that this patient might have
13 weeks.
Oh, 13. We do it at 12 to 13 weeks. Sorry.
Yeah. So 18 to 20 was what they used to say before, but now you can do it earlier. That is what Nivedita is saying. So you have your PLGF and SL soluble factor,
SFLT,
SFLT. So those are things which are along with other things, along with MAP and a lot of other things, have a very high sensitivity and specificity. But that's again Leona Poon's lecture, as Ashish said. So that's a collection of a few data together which can predict preeclampsia in many cases. So those are things. But as you rightly said, uterine artery Dopplers, I think they are almost done
I think
routinely.
Mandatory.
If you're doing at 13 weeks, you'll do it. And 18 to 20 also you'll do it. And but 18 to 20 is a little late to start aspirin. But anyway,
you'll start
aspirin. You'll start aspirin anyway.
Yes, sir. Yes,
so
the other thing, sorry to interrupt once again.
Yes,
Dr. Pratima Radhakrishnan was here in Bokaro, and one point which she mentioned was maternal ophthalmic Dopplers. And she said, if like with the when you do the NT-NB scan, also get the maternal ophthalmic Dopplers, and as the maternal ophthalmic Dopplers, the PI is high. then again you can start on aspirin 150 milligrams.
Yeah, actually, you see, the studies have recently proved that the second trimester, the PI is less useful than the first trimester. That also helps us because we can start aspirin immediately. So that is one important point of doing an uterine PI. I think that it should be included in that. But all said and done, including the PLGF and SFLT1, I'll rather prefer the Gestosis score. I think it's an absolutely clinical score. And as I said, the blood pressure level and the risk factor calculation, if you can do it religiously, I think many of the cases of prescription of aspirin will be there.
Last question, and we'll conclude this session. Ashish sir, what is the recommended dose of aspirin according to the Gestosis score? 75, 150, what is yours?
You see, no dose of aspirin was spared in giving it to the pregnant mother. Those who require aspirin, it started from 75 and it went up to 150. But recently, I think whatever FIGO has said, I think we should abide by that. FIGO has said recently that you should have 150 milligram at night after dinner, and that we should accept. Because there are doses like Eltroxin doses, like 88, like 75, like 60, all these are there. I won't go into that, but 120, 150, I think we should all accept because that is given by FIGO in 2022.
So Dr. Nivedita will also accept for 150 now. Thank you everyone for this interactive session. And it was really nice. And
because Bashav initiated so much of discussion. That is
yes.
Chalo. That's the topic was given by Kalyan.
Okay. Thank you so much.
Support Kalyan, support Monica and Shatabdi and all their activities. That's good.
Thank you so much, sir.
Thank you so much, sir. Thank you.
Thank you.
I also thank our chairperson,
thank you,
Moshmi Madam, Asha Ma'am, and
Monica and Shatabdi. Thank you very much.
Thank you, ma'am.
And Priyankur. Yeah.
And but sir, it was Kalyan sir who got me into Foxy before Priyankur.
And thank you, Dr. Kalyan.
Thank you, ma'am. Thank you so much.
Thank you. Can we move ahead to the next academic session, sir? Yes, sir. Can we have the slides? We move ahead with our effective panel discussion, and which will be moderated by Dr. Kalyan Baramde, sir. The panel discussion is on a very important topic today, that is labor room emergencies, and we have a very eminent expert today with us, our senior Dr. Ashish Mukherjee, sir. Our panelists for today, Dr. Ashish sir is a professor and unit chief at GNHO CSS College of OBGY, Kolkata. He's been the vice president of FOXY, the past president of the Bengal OBGY Society, and the ex-chairperson of the Medical Education Committee, FOXY. We welcome you, sir.
Thank you so much.
Yeah. Our panelists for today. The next slide, please. Dr. Sindhu Bala Madam is a clinical director at Creation Fertility Center at Siliguri, and she is also the consultant at Arogya Nursing Home. Welcome, ma'am. The next slide, Dr. Anupriya Madam is a consultant.
Anupriya is not here.
She's a past secretary of the Bokaro Society. Dr. N. Roy is previously attached as a senior resident to North Bengal Medical College and Hospital, and he's currently posted at Siliguri District Hospital. We welcome you, sir. The next slide, please. Dr. Nivedita Madam is a consultant in the Department of Government Hospital at KM Memorial Hospital, Bokaro. And she's also the in charge of the Priyadarshini Clinic at Bokaro. She has been the past president.
That's it.
Yes, ma'am. We welcome you, ma'am, as a panel.
Thank you.
The next, Dr. Pranamita Ghosh is a gynecologist and a high-risk pregnancy specialist, and ex-assistant professor at Central Referral Center Hospital, Gangtok. She's also the ex-fellow at Ruby Hall Clinic, Pune, and senior resident at MI Imar Medical College at Pune. We welcome you, ma'am. Dr. Rupam Singh Madam is the ex-HOD at Bokaro General Hospital, and for her fortes include endoscopic surgery and urogynecology. We welcome you, ma'am. Dr. Varuna Verma Madam has a special interest in ultrasound and endoscopy. She has been the joint secretary of the ISOPA Bokaro chapter, and she's presented various papers, and she has been invited as a faculty to various AICOGs. We welcome you, ma'am. Dr. Kusum Prakash Madam is at Darbhanga Medical College. She is presently working as a consultant at Muskan Hospital at Bokaro. We welcome you, ma'am. Over to you, Kalyan sir. The stage is all yours for the panel discussion.
We have Dr. Ashish sir who is going to guide us. We are going to have a clinical questions for all. Anybody can answer this. We are not specified to anyone else. And at the end of each question, Dr. Ashish sir will give you a guideline for the same management of that disease, which is very important. So take home messages Dr. Ashish Mukhopadhyay sir will give us to us. So welcome all for this. My slide is seen to Monica.
Yes,
Yeah.
yes.
Yes, thank you. So we are going to have a session where we are going to discuss all the obstetric emergencies, and we have a few questions ready for all of us. And we have already introduced all the panelists, and expert is Dr. Ashish sir. The first case, G2P1L1, post-dated by 7 days. First pregnancy is full-term instrumental delivery, 2.9 kg. This pregnancy was supervised, registered outside. Patient came in labor at other hospital. Referred for slow progress of labor and big size baby. On admission, uterus full term, mild contraction, 6 centimeter dilated, 90% efface, station 0. Pelvis looks to be adequate. What complication one can expect in this patient and how you are going to manage this patient? So now to Dr. Sindhu ma'am, we can start
Yes,
with this.
sir. This patient was in labor at other hospital. And like we know that the patient who has been already tried at other hospitals are not the easy one. We should not always think that we are some extra intelligent and extra powerful so that we can deliver. We should always take such patients in perspective of like why labor delay is there, why baby is not coming out, all the possibilities. Is there cephalopelvic disproportion or is contraction is not adequate? We must assess everything as like new and complicated patients. We should always check our own assessment, like station, rotation, whether she is having a case of obstructed labor, bladder is full, is there Bendel's ring or anything? If we ensure that everything is all right, because she has already delivered a 2.9 kg baby in previous pregnancy, so her pelvis is a tested pelvis. And if baby weight is not very big, like it is around 3.25, we can expect a normal delivery. But with written consent that we might have to resort to instrumental delivery or cesarean section, bradycardia may happen, patient may have to undergo another procedure like, like instrumental delivery or internal rotation or forceps delivery, especially we should take consent. And we should always check and inform beforehand the anesthetist, the pediatrician, because such baby may have, already suffered some amount of intrauterine asphyxia. Patient may require expert neonatal care at the time of delivery. So we can give a short trial of labor, hoping that in another 3 to 4 hours, if she delivers, it's good. Otherwise, we should take a trial of vaginal delivery in the OT setup, keeping everything ready for cesarean section as well. Thank you, sir.
Thank you, Dr. Sindhu, madam. So firstly, second IV line, giving a RL, and then afterwards, I like to do a blood group cross-matching for this patient and keep the blood reserved for such patient. And then I started oxytocin for her. After 3 hours, cervix was fully dilated, head descended, crowning seen, episiotomy given, head delivered, but baby not coming out. Now coming to Dr. Chayan Roy from Siliguri, what might be the cause, Dr. Chayan?
It might be due to already the head part has come out and the shoulder is not being delivered. It's most probably a case of shoulder dystocia, or it may be cords around the neck. So we always assume that a patient who has already delivered vaginally would also deliver the second time as equally or as easily as the previous time. But 3 points to be noted in the first case, that they mentioned the big size baby, number one. Number two was the contractions were mild. And number three, the pelvis seemed adequate. Huh. So it could be a case of, since the pelvis was already tested, we always assume that the delivery would be smooth and fine. But in case of post-dated pregnancy, and if estimated fetal weight is bigger, there could be these complications such as the shoulder dystocia in this case.
Okay, so now coming to Dr. Nivedita, madam. So what is the incidence of shoulder dystocia in your practice? What are the predisposing factors? And any means you can diagnose this antepartum?
The global incidence, they say, is between 0.2 to 3%. However, in my practice for the last 10 years, I have come across only 2 cases of shoulder dystocia. The predisposing factors in this case, which you have given, Dr. Kalyan, is one is postdatism. And if we know by the DOPE guidelines, that is diabetes, obesity, postdatism, and estimated fetal weight. So in this, we have a big baby and we have postdatism. So here, these are the 2 predisposing factors in this case, which you've given, without mentioning the mother's weight and diabetic factors. As well as now diagnosing this antepartum. One is we should have we can, like, if we find that the mother is obese, if we find that the mother has GDM or diabetes, then you think that, okay, this is a case which is going to end up with shoulder dystocia. Anyone with a postdatism thinks shoulder dystocia. And then obviously where you feel that the pelvis is going to be inadequate. But if the pelvis is inadequate, then usually you might have an obstructed labor where the head does not come out. So in these cases where you feel that the bisacromial diameter is larger than the biparietal diameter, so there you have to think of an ultrasound. If you are doing the ultrasound yourself, or you have a very good sonologist who's doing the ultrasound, and that sonologist can actually see the bisacromial diameter and let you know what the bisacromial diameter is vis-a-vis the biparietal diameter, you have a very good idea whether this baby is going to end up with shoulder dystocia. Then of course we have the baby weight, and although they say any baby which is more than 4 kilos, somehow with the women out here, because as it is, the women here are undernourished and they are small, and they have I won't say they have small pelvis, but they are basically small. So any woman I find with more than 3.5 kilos baby in an ultrasound, I really think that, okay, this might end up as a case of shoulder dystocia.
So you are anticipating by doing an ultrasound. That is very important parameter.
And history as well as
yes, previous shoulder dystocia, any maternal diabetes, DOPE she has already told you about. So that is a really good anticipation in cases where you are expecting a shoulder dystocia. Now coming to Dr. Pranamita Ghosh, madam, from Gangtok. What is the management of shoulder dystocia? We have delivered the head and shoulder is stuck. How are you going to manage this?
So management of shoulder dystocia in a labor room setting should be very prompt. First and foremost, we cry out for help. As many number of hands as we can get is much easier for us. Secondly, immediately we hyperflex the legs and we begin the Macroberts maneuver. That is by applying suprapubic pressure on the suprapubic pressure, and immediately we try to disimpact the anterior shoulder of the fetus. Immediately thereafter, we release the posterior arm and we deliver the baby. Sometimes, and most of the time, Macroberts maneuver is successful in delivering the baby.
Right. In my setup, what I plan is shifting such patients to operation theater wherever you are suspecting that the baby is big, keeping the vacuum and forceps ready, followed by such maneuvers which is going to be helpful for us. So can Dr. Rupam Singh tell us about the Roberts maneuver in detail? Dr. Rupam, ma'am, is there?
Just a moment, let me check.
Okay.
No,
Dr. Varuna can take this question? Dr. Varuna Verma, madam.
Varuna is there. Varuna is there.
Yes, madam.
I would just like to point out for the audience that whenever you think of shoulder dystocia, remember that the shoulder is not in the pelvis initially. It is above the inlet, and hence giving constant, a lot of people make the mistake of giving traction on the head, and that simply elongates the neck. It is not going to deliver the shoulder. So that is because the shoulder is above the inlet, and hence has been very rightly pointed by Dr. Paramita. You have to give that suprapubic pressure and not a fundal pressure.
Yes.
Fundal pressure is an absolute no.
Yes, fundal
Yes,
pressure
fundal
is
pressure
going to
can
not
make
going
the
to.
matters worse.
Yes, Dr. Varun,
Yes.
ma'am.
Yeah, fundal pressure can make the matter worse.
Matters worse.
Yeah, the anterior shoulder is impacted under the pubic symphysis. In McRoberts maneuver, we have to extend the leg and we have to take it as, we have to take it towards the maternal axilla.
Thighs
so
to
that
the abdomen, right?
Yes, on the abdomen of the patient, and so that the posterior, so the sacrum is flattened actually. The sacral part of the mother is flattened, and and the baby gets more space posteriorly, so that anterior part is with anterior. As we press suprapubic at suprapubic part, the anterior shoulder gets disimpacted, and that is it.
Yes, very rightly said. So now, Dr. Ashish sir, as an expert, how you are going to manage the shoulder dystocia in labor room? Can you just explain to everyone as a last take-home message, sir?
Yeah, actually, managing shoulder dystocia in today's labor room is easier because they are not labor room table, they are labor room beds now. One on which you are supposed to keep the patient for 8 hours. That is a Government of India recommendation, firstly. But before going into that, I would like to strongly recommend ultrasound in the second stage of labor. You know, ultrasound in the second stage of labor is immensely helpful, and you do not need radiologists for that. Your own obstetric residents will be good enough to diagnose many points which will help you in the management. Now, once the shoulder dystocia is diagnosed, I think, can you hear me? Hello?
Yes, sir. Yes, sir. Yes.
Okay,
Yes,
okay. Okay, actually, my picture is off, so I thought. Okay, so once the shoulder dystocia is diagnosed, immediately you do what the first catheterize the bladder. You evacuate the bladder. Secondly, as correctly pointed out, you try and do the McRoberts maneuver first. What is McRoberts maneuver? That is hyperflexion of the knee joint, a hip joint, and keeping the thighs pressed to the abdomen. As long and as far you can do, that is better for you. So that will give you some space. And then suprapubic pressure. Suprapubic pressure is immensely helpful in releasing the anterior shoulder. As we know very well that the anterior shoulder is hinged. It is not stuck there, it is hinged there. So you have to unhinge that. Much like we do in the vaginal delivery of head. We depress the head towards perineum, but here that mechanism won't work unless and until hyperflexion is done and also catheterization done and the suprapubic pressure is given. Because it takes some time and some effort to release the anterior shoulder. Once you release the shoulder, then you concentrate, then do not try to drag the anterior shoulder towards for the delivery, but go posteriorly and take out the posterior. So I think that is very, very important to manage the vaginal delivery. It is not only the position of the mother, but also the sequence of events. And once you release the anterior shoulder and release the posterior shoulder, rest of the things becomes easier. And of course, adequate hydration of the mother is important. IV fluid. Sometimes she may need some anesthesia, but normally we do not prefer anesthesia in such conditions because towards the end we need the bearing down efforts from the mother. So there are one or two points. One is catheterize the bladder, positioning of the mother properly, hyperflexion of the hip joint and suprapubic pressure, release the anterior shoulder, deliver the posterior shoulder, and then your job will be done. Only
Thank
there
you.
you need
Yes, sir.
anesthesia.
Yes, sir. Thank you so much, sir, for detailedly explaining about the shoulder dystocia management in the labor room. Coming to Dr. Kusum Prakash, what are the maternal and fetal complication and what are the medico-legal implications of shoulder dystocia?
And the complications occurring due to shoulder dystocia are to the baby are brachial plexus injury, Erb's palsy or Klumsky palsy. There may be humerus fracture, and maternal complication are cervical injury, vaginal laceration tear. There may be complete perineal tear, bladder injury, or sometimes sacroiliac joint dislocations. In
Also,
shoulder
Dr.
dystocia,
Yes, sir.
Also, they could be could be because of prolonged labor. They can be post uterine atony and postpartum hemorrhage.
EPH.
They can be for the baby. They could be hypoxic ischemic encephalopathy, stillbirths, or even IUDs. And we can have long-term sequelae of bladder and bowel dysfunctions because of the nerve injury, prolonged nerve compressions which occur in such cases, and nerve injuries.
Yes. Also, Dr. Nivedita, these are the complications. If they happen, there are medico-legal importance of this also. So can you just enumerate about this?
The one is obviously communicate and document. So one has to inform the relatives that even before you take up, when the moment you see a big size baby, always inform them that, okay, the baby is a big size and these complications can occur. In a diabetic mother, inform that these are the, if you have any of these histories, please inform before and document and let them know that these things have been documented in the presence of a witness. Now, if such a complication does occur, the one is at the neonate, you have a whole team with you. That means the neonatologist has to be present during the delivery, because if you do not have a neonatologist at that time, it is again a medical legal problem. So the neonatologist has to be present for the baby resuscitation or to handle most of the complications. Then it has to be a combined effort to find out for the maternal complications as well as the neonatal complications. And presence of a birth companion here is, although it's not a medical legal issue, but it helps because the birth companion sees whatever is happening and the efforts that you are putting in for the mother and the baby. But as it is definitely a medical legal problem, because any complication to the mother, even a long term like incontinence, even a long-term complaint, they're going to blame you for that prolonged labor. For the baby, definitely they're going to blame you. So everything should be documented beforehand. And if things have happened like that, even the time of delivery, the time, how long it took for the baby to be delivered, when did the baby take the first breath, all these points should be documented.
So rightly said, documentation is very important. Secondly, presence of neonatologists. And lastly, we need to have a partogram ready for such patients. If you have delay in any of the partogram, you can go for a cesarean section early. Even those cesarean section will be really difficult because it will be a second stage cesarean section. You need to take a consent of that also. So coming to the second case.
Just before we...
Yes, anybody wants to add? Dr. Ashish, sir, sorry.
Yes. One word of caution that the same shoulder dystocia may happen in abdominal delivery also.
Absolutely.
Yes.
Same mechanism applies. Okay. So just a note of caution for all of us.
And birth injuries can occur to the baby even in an abdominal delivery.
Yes, sir. Thank you so much. Coming to the second case, she's a 27-year-old lady, G2P1L1, first pregnancy, cesarean for breech 3 years back, post-operative period uneventful, catheter removed after 48 hours, now supervised, registered full term. She comes at 38 weeks as per first ultrasound. She's vertex, expected fetal weight 2.8 kg. What is the plan of management for this patient, as this patient is keen on VBAC? Coming to again start from Dr. Sindhu Bala madam.
Thank you, sir. Actually, everybody would like to know what is my probability, like what are my chances to have successful vaginal delivery. And it depends on us and our assessment to say, like, this is your chance. And how do we calculate it? We have certain fixed guideline and certain variables. Fixed guideline in the case like the cephalopelvic disproportion, size of the baby, we usually know by our hand examination and by ultrasound baby weight measurement. And size of the pelvic, like you usually do not ask for X-ray pelvimetry, nobody does it. We do our hand examination and we see that pelvis is adequate or not. And third and fourth factor comes again into play. Whether baby is getting adequate blood supply or not, Liker is adequate or not. If there is any factor which can lead to intrapartum hypoxia, like if SD ratio is very high, if baby is getting uteroplacental insufficiency, in those cases, we will be avoiding normal delivery. Fourth thing, if patient is not very keen, like if they said, we do not want to take 1% risk also, patients liking patient choices also now very important. And then we will give them the options. If they still says that, then we will give them, you have 30% chance or 40% chance or 50% chance. Because previously it was done only for fetal indication. There was no maternal indication for cesarean. So this time if her pelvis is adequate, her blood supply, fetal blood supply is normal, baby weight is normal, and we have all the setup to do proper monitoring of labor, including partogram, including her scar, including her baby's heart rate continuous CTG monitoring, we can give her a guarded trial of labor. Of course, we will have 2-3 things in our mind. I usually do not offer Serviprim for induction of labor in such patients. Second thing, I usually avoid epidural analgesia, even if they demand, because sometimes they can mask scar dehiscence very well. Patient has already gone into scar dehiscence. I have seen many times, and patient doesn't feel any pain. And fourth important thing, her cervical condition. If cervix is not favorable, then, and blood supply is okay, we can let her go up to like 39 and even up to 40 weeks. And if she insists on having a VBAC, we can induce with syntocinon if cervix is favorable. Once it becomes favorable, I mean, like if effacement is all right, cervix is soft, 1 centimeter dilated, then we can start syntocinon drip, starting with 2 units in a normal saline drip, then gradually increasing up to 30 drops per minute, then 45 drops per minute, then up to 60 drops per minute, and then increasing the strength of the syntocinon. And persistence towards delivery profile, like we are persisting for the delivery, we should have 2-3 indications, like she should progress easily, like adequate progress of labor should be there. She should not have any fetal bradycardia. She should not have any like maternal tachycardia or panic. Sometimes patient starts shouting so much, we are unable to make out whether she's shouting because of labor pain or she's shouting because of scar rupture. And that makes things very confusing. So if everything goes smoothly, we can expect a normal trial of labor lasting up to 10 to 12 hours. But in that case, labor should progress smoothly according to the partogram, according to the guideline. It's not like she did not progress for 3 hours and we are insisting another trial of 3 more hours. We can give 1 hour or 2 hours extra, but not a longer trial of labor, because then that labor pain is causing stress on the previous scar. And scar thickness is now in a vogue. People say that we should see the scar thickness prior to trial of labor. But yes, we do see, of course we see, but it is the dynamics of labor which decides whether scar is going to withstand the trial of labor or not.
Very rightly said by Dr. Sindhu Madam. Now coming to Dr. Chayan Roy, are you going to do induction for this patient or are you going to wait for spontaneous labor? Dr. Chayan Roy.
Spontaneous.
Yes, Dr. Chayan, you're audible. Now, can you unmute, please, Dr. Chayan? Unmute, please. Dr. Chayan, you are not audible. Please unmute yourself. Yes, now you are.
Spontaneous on the
Again, you are muted yourself.
spontaneous onset of labor is always favored because induction may result in scar dehiscence or scar rupture. And in this case also, individualization should be done because we have to know whether what was the indication of previous cesarean section, whether it was a recurrent cause or a non-recurrent cause.
Non-recurrent cause.
Yes,
breach.
Breach and fetal distress is a non-recurrent cause. And also, the placental localization is also very important because post-cis pregnancy, if the anterior low-lying placenta, we have to know the location of the placenta, whether associated with any obstetric complications, whether the mother is having anything, then if the mother is associated with any obstetric complications, VBAC shouldn't be tried. In all these cases, spontaneous onset of labor is favored. Even if we try to induce, mechanical induction such as Foley's induction is than prostaglandins.
Very rightly said. If
Very
you
right.
have some other
In case
factors,
of
then you can do a mechanical induction. But Dr. Nivedita, what is your say about previous LSS with PIH, previous LSS with GDM, two associated factors? What you are going to do, whether you're going to do a LSC
when I was doing my house job in
Residency.
gynae ops from Kolkata, my boss told me one thing: if there are two complications in any case, go in for a C-section. So a previous CS with any other complication, any other obstetric complication, I would like to go for a C-section. Now,
Yes.
frankly speaking, not for the records, but when induction only mechanical. I'm sorry, but I do not use any other method for induction in a previous CS. Only mechanical is with Foley's transcervical Foley's catheter if I have to induce. And augmentation, it's only by monitoring of contractions. If there are contractions are less than 3 per 10 minutes, lasting less than 20 seconds, only then I start oxytocin. Only drug is oxytocin, and that too under strict guidance, because then I have to sit out there and monitor
yourself.
Monitor it. A CTG, as you said, role of CTG is
Partogram.
imperative. CTG and the labor care guide. These two things, or a partogram, whichever you put it. These two things are imperative because the CTG is going to give you the contractions as well as the fetal heart rate variabilities of any. And if any problems in that, I think in today's world there is no use being going for heroic measures. You don't gain anything, and if anything goes wrong, you really get sunk so badly. It is better to take up for C-section. Again, in a VBAC, always take documentation and communicate and document about any complications which can occur beforehand.
So you are not going to be jealous about the VBAC or normal delivery. If it is happening in a normal fashion, it's fine.
It's fine.
Otherwise, if there is any partogram changes, CTG changes, you can always go back to the. Now this patient is progressing well. Dr. Nivedita, what are the signs of scar dehiscence you can find in this patient who has gone into the active labor?
One is, of course, the signs of the mother. One mother, you will suddenly, she will say, she'll give one history of acute pain. In fact, the mother is very particular. She'll say something gave way. She's like, अंदर में पता नहीं कुछ लगा कि खुल गया मेरा. Then secondly, you can see the contractions which were occurring in a very smooth fashion. Suddenly you will feel that there is one thing on top and there are no contractions. The contractions have absolutely gone. The fetal parts become palpable if the fetus has come out. With scar dehiscence, you may not get it, but with the scar rupture and the fetus coming out, suddenly the fetal parts may be palpable. But before that, if your patient is on a CTG, you will get variable decelerations, and that is the first sign of scar dehiscence, even before the maternal pulse starts deteriorating. So we were told that monitor the maternal pulse and monitor the fetal heart rate. If these two things, if you get tachycardia and if you get variable decelerations on a CTG, then you think of scar dehiscence.
Microscopic hematuria, few people say it
absolutely
can
absolutely anything, any other signs of movement, that is when the scar rupture is occurring.
Right. Dr. Rupam Singh, madam, what is the crash LSCS and what are the signs of rupture? Dr. Nivedita has told you about the dehiscence. Now you talk about the rupture.
Rupam is not the Europass, Varuna.
Dr. Rupam Singh, Dr. Varuna Verma, ma'am.
Yeah. Crash LSCS is when we are ready for giving a trial of stipulated time period, mostly around 10 to 20. Within 10 to 20 minutes, we should be shifting the patients within 5 minutes, and within 10 to 20 minutes, that is crash LSCS. Mainly, it is the time, dependent on the time. Signs of uterine rupture, it is again in it is going in other I mean, it is greater degree than days.
There is a
Varuna,
disturbance.
your network is poor, so please switch off
patient
your
will
video.
have an extreme degree
So,
of
Varuna
pain.
ma'am, can you just switch off your
Hemodynamic.
video and talk?
Varuna, switch
Stop
off your
your
video.
video.
Your
Yes, now you
yeah,
can
thanks,
talk.
thanks.
I'll do that.
Yeah.
Yes. So, where were we? Yes, her dynamics will, hemodynamics will worsen. She may go, her pulse will increase greatly. Her BP will fall. The amount of bleeding she is having, they will be we can see the blood in the Poli's catheter, and the heart rate. Fetal heart rate will be erratic, or it may even lose the fetus. So the main thing is the hemodynamics will be greatly increased and have extreme pain, and the contour of the uterus will be lost.
Yeah, only one thing is you have to keep your OT ready for such patients who are undergoing VBAC trial, and then only you can go ahead with the procedure. Secondly, coming to Dr. Rupam Singh, ma'am, I can see her.
She's not. Oh, she's
Yeah,
coming.
she's
Okay.
there. So, ma'am, you had started the cesarean and you find that there is a uterine rupture. What is the management? When you are going to do a conservative surgery and when you are going to do an obstetric hysterectomy? Dr. Rupam, ma'am. Dr. Rupam Singh, ma'am.
Please unmute yourself, Dr. Rupam.
Yes, yes.
Yes, am I audible?
Yes, ma'am.
Yeah. Uterine rupture in this scar dehiscence is mostly manageable because it is not upper segment, it is lower segment scar dehiscence. So bleeding is less in these cases. So we can manage this by conserving the uterus. And earlier we used to see that scar rupture in multiparous after prolonged labor, that was on the upper segment, and that was usually on the upper segment on the both uterine arteries were used to be lacerated, and patient used to come in shock, severe shock. That time, sometimes it used to be very difficult to save the uterus, but in scar dehiscence, mostly we can save the uterus. So we can do it, you can repair it in layers, and we can go for this thing. We can conserve the uterus as well.
So desire of childbearing, whether it's a low transverse uterine rupture, any extension into the broad ligament, cervix or paracarpus, and easily controllable uterine hemorrhage, good general condition of the patient, and no clinical evidence of evolving coagulopathy, then you can go ahead with the conservative treatment. Otherwise, you can go ahead with the hysterectomy.
Yes, sir. If it becomes life-threatening situation, then we should go for in time. We should make decision for obstetric hysterectomy.
Yes, ma'am. Thank you. Dr. Kusum Prakash, madam, has joined.
Yes, she was there.
Yes. What are the risk factors for uterine rupture, Dr. Kusum, ma'am?
History of previous scar like myomectomy or some other surgeries, or if the previous cesarean is classical or inverted T-shaped.
Very right.
Previous 2 or more cesarean sections. The pelvis may be contracted, or multiparity. Big baby. The baby weight more than 4 kg or 4 kg. These are the factors for uterine ruptures.
Right.
Or if uterine anomaly is also. A multiparative, grand
Because
multiparative.
of prostaglandins, obstructed labor, and macroscopic babies, and traumatic due to forceps or some delay. Now coming to Dr. Sindhu Bala, madam.
Yes, sir.
In which patients will you consider VBAC as an option? How are you
First,
going to decide the
the predictability,
VBAC?
the positive predictability,
Yes,
like
ma'am.
where I can expect a successful VBAC. Patient should be first willing. Second, she should have adequate pelvis. Third, she should not have any cephalopelvic disproportion. Fourth, her she should be at the same time, she should be willing to give up the VBAC. I get usually sign done. If there is no successful VBAC, she may need to take up, she need to be taken up for cesarean also. So the chances of successful VBAC depends on her baby's condition. Size should be appropriate, not should be very big. Pelvis should be adequate. Cervix should be favorable. And we should have good monitoring team. We should give a adequate trial, keeping everything in check, like her baby's heart rate should be monitored, labor progress should be monitored, and we should have all the alternative arrangement if we have to abandon the VBAC. If patient is not willing for cesarean, she insists like मुझे 100% normal delivery ही चाहिए. In that case, we decline very politely. Like we cannot predict 100% positive trial. We can give trial, but we have to keep that option also under consideration.
So written consent is must for medical legal point of view whenever you are considering the VBAC trial. Now coming to Dr. Chayan Roy, what is, you are done a cesarean, how she is going to plan a future pregnancy? If she has a dehiscence and now you have sutured it back.
After conserving the uterus, we must provide the detailed OT note, the how much extension it was there, how the repair was done, whether it was done in a single layer or 2 layers, how much blood loss was there, and the detailed obstetric notes or the OT note should be provided for the present dehiscence or the rupture that we have repaired. Next, we have to counsel them very well that there is a possibility of rupture in a future pregnancy. So planning a pregnancy, next pregnancy should be delayed, if at all. And if they are willing to conceive again, the elective cesarean section should be performed at around 38 weeks after administering the corticosteroids. Since the rupture has occurred this time, we might already electively admit the patient by 36 weeks. So that, and we can reassess mother and do a planned elective cesarean section the next time. Now also, we should counsel that if she might have onset of pain before the 36 weeks, and she should report to the nearest facility or hospital immediately if the labor pain sets up earlier.
Thank you, Dr. Charan. Now coming to our expert, Professor Ashish Kumar Mukhopadhyay, sir. Few words about VBAC, uterine rupture, and scar dehiscence, sir.
I'm very happy to announce that from April 2025 till today, the November, we have delivered 82 cases of VBAC in our hospital. So dealing with post-cesarean section pregnancy has become a rule rather than exception in our institution. So I'm afraid I cannot give you the exact statistics. Book figure is 60 to 80% success rate. In reality, what happens? Yes, your question was very nice. The patient wanted badly a vaginal delivery. What we see in reality, most of the patients will come and say, doctor, please do the cesarean section for me, tell me the date. Okay, so that is the situation. Now, VBAC, I think in my opinion, is an excellent opportunity, to reduce the cesarean section rate, which is so profound in our country now. It's increasing private sector and government sector alike. And to prevent, I tell my PGs that what cesarean section you do today are the post-cesareans tomorrow. And a chunk of them will go into placenta accreta spectrum. That is the reason why we have put a focus on the VBAC. And for this VBAC, we have a 10-point assessment system, which starts from the antenatal period. We do it in the antenatal clinic. And I myself see these patients very carefully. And thorough antenatal care is very important. And I do not believe in elective cesarean section also, of course. But if you talk about delivery, then I think spontaneous onset of labor is important. I think Nivedita has talked about this intracervical Foley's balloon catheter, and we always do that in cases where the spontaneous labor doesn't happen. But we are not disappointed. In 30% of cases where spontaneous labor starts, then we are benefited only with the monitoring of the patient. So we have a good team in the labor room, including the nursing staff, who do it very well. And not exactly the labor care guideline we are following, but they are doing it well. So those 10 points, I think we can discuss sometime again. But the ultrasound measurement of the scar thickness, I have found a quite reliable parameter. And responding about the pain.
What is the cutoff, sir? When you just scar thickness?
0.2 centimeter, that is 2 millimeter, is the limit below which we do not allow. I mean, we go for elective cesarean section.
And 3 millimeters.
We follow 3 millimeter also.
Okay, 2 or 3, whatever you take it. But we have seen in our series 2 giving better result. Now, about the pain, I must tell you that I have seen more patients with dehiscence without pain than patients having dehiscence. The typical presentation of the pain is usually absent in particularly cesarean section scar. You have to remember that the scar itself is avascular, nerve content is minimal, and therefore what happens, the patient doesn't feel much pain, and we have seen many cases of silent rupture or other dehiscence. And another thing is that another interesting observation, diabetes in pregnancy had more painless dehiscence and rupture than the other normal glycemic patient. So these are the things that we have found, but the success rate is good. Initially, my team was very skeptical. No, sir, the patient don't want it, etc., etc. I said, let me counsel with them. And believe me, patients do like to have vaginal delivery in any setup because that is cost effective to them. So I think we should put more stress and we should promote VBAC. And thank you, Kalyan, for promoting this topic, because I think I'm a strong proponent of VBAC. I am not because I have been successful in so many cases of VBAC, but I have seen that there is in a feeling of the same difference between ventouse and forceps. In ventouse, the patient feels that she has delivered the baby herself. You know, that is the difference between ventouse and forceps. Whereas forceps, she feels there's something being dragged down. But ventouse, she feels that she has delivered the baby herself. So it's like that. You know, when she delivers the baby vaginally, she is very happy. And another last point I'd like to mention, that do not go for routine palpation of the scar after delivery of the baby. That is not only useless, but also maybe dangerous at some time. You know, so do not have the practice of, palpating the scar after delivery of the baby. Thank you.
Ashish, the one question I would like to ask, sorry, I'm not a
Yes, ma'am.
moderator here.
It's okay.
I would like to ask about labor analgesia, because I feel labor analgesia can be given and it does not hinder it does not mask the dehiscence. What is your view about labor analgesia?
My take is that 40% of cases, they do not complain of pain at all. And I find a surprise dehiscence. Secondly, we do not have the facility of epidural analgesia here also. And that is why we prefer Entonox. Given excellent result in VBAC cases. Try and use Entonox, you'll be surprised. Not in other cases, but I have used particularly in VBAC cases. Entonox is giving wonderful result. That is my suggestion.
Thank you.
So rightly said by sir, VBAC will give you a faster recovery, shorter hospital stay, no abdominal surgery, less bleeding, but you have to be judicious enough to decide which patient you can deliver by VBAC, because ultimately in a smaller setup, if something goes wrong, it's the doctor who is responsible. But wherever possible, you should give judicious trial, because worldwide literature says around 70 to 75% success rate to the VBAC. Thank you, Ashish sir, for your valuable inputs about the VBAC. Now coming to the third case for Dr. Nivedita Datta madam, 32-year-old third gravida, 2 FTND, 6 years and 3 years back. No history of any complication in previous pregnancies. Came at full term, pain in abdomen, mild contraction. On per-vaginal examination, 6 centimeter dilated, 60% effects, augmentation by oxytocin, delivered in 3 hours by staff nurse. Baby cried immediately, but mother suddenly collapsed, a mass coming out of vagina, placenta not separated. What is the management and diagnosis of this?
The diagnosis is uterine inversion, and in fact, this would be a grade 3 uterine inversion because the mass is outside the vagina. And the management is obviously, one is resuscitation, and two is repositioning of the uterus. Then, and finally, removal of the placenta.
So, can Dr. Dr. Rupam Singh ma'am suggest about the predisposing factors of inversion of the uterus?
If I tell about predisposing factor, it used to be, I have seen this emergency in our labor room, but nowadays it is less seen. I don't know what is the factor behind it, but predisposing factor is
Your
multiparity.
staff nurse has done this, so it's a iatrogenic complication. Anything else you
And
want to add?
it happens in it used to happen in cesarean section also earlier, but nowadays it is not occurring because we are very very thoughtful in delivering the placenta.
Better uterotonics has come in the market.
And another thing is AMTSL for all, universal AMTSL.
Active management of third stage of labor. So, Dr. Nivedita, can you just guide us about the anesthesia, how we are going to reposit back?
Usually here general anesthesia with preferred, especially earlier is to use halothane. Now they're using isoflurane. Am I audible? Because I think my network is playing some
Yes,
problems.
you are audible, ma'am.
Now then they're using isoflurane also. The other thing, anything which causes relaxation of the uterus, because here we want the uterus relaxed so that we can repose it. A contracted uterus is very difficult to repose, and after we repose the uterus, then we want uterine contractions. So we have to have a good, the anesthetist and the intensivist not only resuscitates but is also in tune with us about relaxation of the uterus till reposition and then allowing contractions to occur.
Okay, rightly said. Dr. Varma madam, anything your vaginal reposition is not possible? Any route, other route like abdominal you think of?
Sorry, I didn't get your
You
question.
try to reposit the uterus back, inverted uterus by vaginal route. Can you just try by abdominal route if it is not possible? Or you are going to do combine or only vaginal?
We can do it by both routes, and we can do it together. Like first, as Madam said, that first we should give relaxant anesthesia, and then we should try to repose it with fingers to see whether it gets reposed or not. And if it is not possible, then maybe we can try by abdominal route as well.
Right. So there are complications of inversion like PPH, chronic
Yeah.
inversion, shock.
Sometimes what happens is that the
Neurogenic
cervix
shock.
is very tightly.
Neurogenic shock, yeah.
Cervix is very tight. After the inversion, the cervix is forming a band kind of structure which has to be cut so that the fundus of the uterus can be reposed. So when cervix forms a band, then reposition of the fundus back is difficult. So we have to cut that band. Yeah.
Dr. Kusum Prakash, madam, chances of recurrence in the future pregnancy, can you just highlight about this? The future pregnancy, ma'am, next pregnancy. Dr. Nivedita, madam, can you just guide about
Yeah,
this?
there are definitely chances of recurrence in the future pregnancy, and the woman should be made aware of it. That okay, this can occur. This can occur again. So again, you should have an institutional delivery, because sometimes it is not just the fault of the paramedical staff or the medic who's delivering. Sometimes there is the it could be the problem with the uterus also. The uterine tone sometimes is relaxed, and hence it comes out on its own. The inwards. Sometimes there may be other associated factors with as a uterine malformation or uterine problems, which can also predispose to the descent to the inversion. So there's definitely a chance of recurrence in the future pregnancy, and she should be advised accordingly for a proper institutional delivery in the next pregnancy too.
So management of shock is very important.
Absolutely.
And followed by, you have to give anesthesia and do the reposition as early as possible. Now coming to our expert, Professor Ashish Kumar Mukhopadhyay, sir. Can you just enlighten about this case of uterine inversion? What is your experience in the medical college practice?
Yes, actually, in acute cases, the management focus is on control of the hemorrhage, resuscitation, because most of the patients are in shock, and also sometimes we need uterine relaxation. But I haven't needed uterine relaxation more often than not, and the hydrostatic method I have found is very useful. It doesn't look very convincing, but once you try it, you will see the result is very good. I have tried that, and I've seen a simple, saline infusion set and then the enema can. I have been able to do this, And yes, the incidence has come down recently. I mean, of late the incidence is less, but still they happen, and they require intense imagination. In fact, this is one of the causes of the obstetric collapse, immediate postpartum collapse. So we need to be very careful. Usual resuscitation rule follows of ABCD, and then gradually, the vaginal route is always preferred. An abdominal route I keep reserved for the chronic inversion cases, not for acute inversion cases. I haven't needed till date any case which needed abdominal, correction. Future prospect is good. Only thing is that you need to have an institutional delivery and careful counseling of the woman that you need to take care of your uterus, because once it has come out, you need to explain everything to them, and it has got a tendency of coming out repeatedly. As Nivedita said, there may be some inherent weakness of the muscle fibers, so it can happen in the future also.
Thank you.
It's imperative that the juniors are drilled in reposing the uterus, because when it comes, then the mistake most people do is that they tend to repose what comes out, what comes out last.
Last will come first.
Yeah,
right.
So they tend to do the other way around.
The central part, the edema happens, and then it will refuse to go inside.
In fact, absolutely. But that is a mistake a lot of people do, is that they try to, because that central part is bulging, they try to push that one in, and they get stuck.
Correct. Absolutely.
Thank you, Ashish sir, for this input. Now coming to the last case. This is for Dr. Sindhu Bala madam to start. 4th gravida, previous 3 FTND, 9 months amenorrhea, in labor, good contraction, uterus full term, FHH regular, 5 centimeter dilated, 40% efface, station 0, BP is 140/90, urine albumin trace, HB already 8.5. In 15 minutes, suddenly variation in fetal heart notice, constant severe pain in abdomen like a atonic pain, atonic contraction, mild bleeding. How to proceed in this case, Dr. Sindhu Bala madam?
Yes, sir. This patient has previously already diagnosed case of mild PIH and anemia as well. This puts her under a high-risk pregnancy and hyperdynamic circulation. And suddenly she has severe pain, which is constant. It usually happens if they have abruptio placental. And here we are witnessing rather dip in fetal heart rate. So bleeding is slight, so that does not go according to why heart rate is dipping so much. So she might have more of concealed hemorrhage rather than revealed hemorrhage. So there is a placental separation which is causing fetal bradycardia as well as giving constant pain. Now the further decision will depend whether we can expect a faster delivery within 1 or 2 hours or not. But before that, we have to again counsel the patients about the complication which has just happened. And I think we should already have arranged blood and blood products in such cases, because such patients have coagulopathy as well. And since she has already had abruptio, she might need blood products and blood both. We have to give requisition for that. Blood pressure is not high, still we have to lower it down. We have to replenish the lost blood volume, whatever fluid we have, crystalloid, colloid. And once we have managed patients, and we try to give oxygen also, like in order to deliver more oxygen to the baby, we try to get blood from the blood bank. We try to expedite the delivery if there is not much of intrauterine hematoma. We should all have access to the ultrasound, even during labor room. And if hematoma is quite significant, that will change our course of action. If hematoma is significant, it is separating the placental bed and it may cause further fetal jeopardy. We can have intrauterine IFD if we try longer with further oxytocin. If hematoma is more, bradycardia is persisting, I will take such patients for immediate cesarean. I will not give further trial of labor.
Rightly said about the management. Ultrasound is very important. Keeping blood products handy is important. And lastly, the blood tests like PT, INR, BTCT, and PTTK is going to be helpful with the platelet count. The management, madam has rightly said about whether she's about to deliver and hematoma is small, then you can augment the labor and go ahead. Otherwise, if hematoma is big, then you can go for a cesarean section. Now, coming to Dr. Chayan Roy, what are the effects of abruptio placenta on fetus and mother, and how you are going to manage the maternal part in detail? Dr. Charan Roy is there. Next comes Dr. Nivedita Datta, madam. Can you just elaborate about this?
Yeah, since the baby, the mother is already, the placenta is already separated, so obviously we know the vascularity to the fetus is compromised. Hence, there is an increased risk of stillbirths and intrauterine fetal death. The effect on the mother is hemorrhage. Is the effect of hemorrhage? Is the effect of the concealed blood on the uterus? So one, you will have PPH, and this PPH could be a thrombotic PPH also, because here we have the coagulation factors which have been utilized, and then we since we have a cuvular uterus in this, that too has a difficulty in contracting, and so we can have a atonic PPH. So we have a thrombotic PPH as well, punched with a atonic PPH. So this is second cause is PPH. So hemorrhage and PPH, then the mother can go into DIC, which can be fatal for the mother in this case. So basically we have complications. So the baby is of hypoxia, which could be stillbirth and IUD, for the mother of hemorrhagic shock, either, and DIC.
Right. Very rightly said by Dr. Nivedita, madam. Both fetal as well as maternal complication can occur. This is a medical and surgical emergency. You have to be really on your toes to deliver these babies, and NICU care has to be given if there is any fetal hypoxia. Now coming to Dr. Rupam Singh, madam, what are the risk factors for abruptio? Dr. Rupam Singh, madam, is there?
Dr. Kalyan, the previous slide.
Dr. Rupam Singh is there, madam? Okay, Dr. Kusum, madam, can take this, or Dr. Varun Verma can take this.
Hello, sir.
Yes, Dr. Varuna, ma'am.
So what was the question?
What are the risk factors in abruptio placenta?
Risk factors to the fetus
No. The risk factors for abruptio placenta. Who are the patients who are likely to go into
the patient which can go into abruptio placenta?
Yeah. for abruptio placenta, there are some, if the placenta is not placentation placental adhesion to the uterine wall, if it is defective, like it can be due to some structural abnormality of the uterus. The most common cause, however, is in cases of PIH and hypertension. The second thing is trauma, trauma in cases of multiparity.
Polyhydramnios.
Yeah. In multiparity, in a great distension of the uterus, like in multiple fetuses, twins, or excessive polyhydramnios, or sudden decompression, or like if there is polyhydramnios and suddenly the membrane ruptures. So in sudden decompression also, the uterus the placenta can get separated from its bed.
Rightly said by Dr. Varuna Verma. Dr. Kusum, madam, can you just guide us about what is revealed and what is concealed, how management differs?
Kusum?
Yes, ma'am. When the bleeding from the placenta comes out from the vagina, it is called revealed. But when it is behind the placenta and which do not come out of the cervix, it is called concealed.
Right. So how are you going to, what is the management difference between this revealed and concealed?
In revealed,
if patient is in labor, then you can do an artificial rupture of the membranes. Ultrasound is done, but patient not in labor, then depending on the weeks of gestation, you decide whether you want to go for a ARM with oxytocin. If less than 37 weeks, you can conserve it. And if in cases of concealed hemorrhage, these are the patients where ultrasound diagnosis is very important. Dr. Nivedita Datta,
Yeah.
what are the causes of maternal collapse?
Before that, I would just like to point out one thing about revealed and concealed is that in revealed, we can assess the amount of blood loss because we have now methods of visual estimation as well as quantitative estimation of blood loss. In concealed, majority of us underestimate the blood loss, and hence we transfuse less to the mother, which
and these
ends
are the
up
patients
in
who can go into DICI.
yes, and renal insufficiency, because we usually tend to under transfuse with these patients. Okay, now the cases of postpartum collapse. Postpartum collapse, we remember the 4H, the H and the T's, which we says anything when we say any problem which occurs, which decreases the oxygen supply to the brain. Now this could be due to decrease of the blood supply or decrease in the oxygen carrying capacity of the blood. So this could be hemorrhagic shock, it could be hypovolemic shock, it could be hypoxia. Then you can have metabolic problems like hypokalemia and hyponatremia, temperature differences like hypothermia. Then decreasing the blood supplies again by embolisms like thromboembolism. Alcohol toxicity, local anesthetic toxicity is very common. Local anesthesia toxicity. Then again, decreased oxygenation is by pneumothorax or tension pneumothorax. So just anything, even like basilar, embolisms in the blood clots in the base or some anything. Pericarpum myocardiopathy, cardiomyopathy, another very important cause because that causes decreased blood oxygenation. So all these are causes which can cause maternal collapse.
Thank you, ma'am, for explaining about the 4H you should remember, and 4T, hypovolemia, hypoxia, hypo or hyperkalemia, hyponatremia and hypothermia, and 4Ts, thromboembolism, toxicity, tension pneumothorax, and tamponade, and preeclampsia and eclampsia can be causes of maternal collapse. Now coming to the last question, and this is for Dr. Dr. Sindhu Bala, madam.
Yes,
how we are going to proceed in a case of sudden maternal collapse? Any protocols you follow? And whom do you call for help?
Sir, this is a dire emergency and we call whatever help I can get. And of course, I will call for an intensivist or an anesthetist and an RMO doctor. And the management is same, A, B, C. We will secure airways. We will feel her pulse. We will see her oxygenations. Even just putting pulse oximetry, we can see whether, we will see whether she is breathing or not. First, we have to secure airways, tilt her head down, keep the foot end up, try to give her oxygenation by whatever means we can. Even we have to give, we put a gauze, we give mouth to mouth, we give through embo bag, we can try to intubate her. And of course, she is if in the labor room, she must be having a IV line. We will try to increase the IV normal saline supply. We will try to give oxygen and we will see whether she's conscious or not. Because if she's not conscious, that increases our problem. Because then it is very difficult to make out whether it is due to CNS hypoxia or whether due to embolism. And first we will secure airway, then breathing by whatever means we can, put an airway, put endotracheal tube, secure her oxygenations till we can take her to ICU for ventilatory support. We will start giving embo bag, oxygen through embo bag. We will secure IV line and we will see her pulsation and we will see oxygen supply. If she does not have heart rate, like she has stopped breathing and she has gone into a rest, we will try to give CPR, cardiopulmonary resuscitations. We all have emergency trolley in our, that is called crash trolley. We have IV adrenaline. We give IV bolus adrenaline in such patients and try to start dopamine as well. And usually with CPR, we get heart, immediately we get some heartbeats. Usually it comes if it is due to some sudden cause and not very, some ominous thing. Then we get heart rate, then we keep on giving her, IV fluid, oxygen. And by the time we have the help of anesthetist, and then we start evaluating what could have gone wrong. It is very difficult to rule out embolism. It is very difficult to rule out immediately that cardiac failure, that cardiomyopathy, madam has said, it happens in many patients. However, few obvious causes like rupture uterus, bleeding, and these can be easily make out and we can start treatment according to the etiology. But first we have to focus on resuscitation.
ABC, yes.
Yes.
Very rightly said. ABCD are the principles which you have to follow. Ensure that there is a breathing, C, pulse, BP, fetal heart rate, C for regularly assessing MEWS, identify cause of collapse. During CPR, establish IV access, high flow oxygenation, intubate and give continuous chest compression, correct reversible causes, give adrenaline if she's not having the circulation, and consider atropine and other drugs till the time physician or anesthetist come. Now coming to the last question, which anybody should not face in their life, that is, when do I perform a perimortem cesarean section? And this question is for Dr. Chayan Roy, sir. Dr. Chayan. Dr. Nivedita, ma'am, this is the last question for you.
Okay. If we see that, okay, now this woman, an antenatal woman with a maternal collapse, and we have tried and we found that she's not recovering, so, and we need to deliver because the uterus itself, the baby is compressing on the major blood vessels and the baby has to be delivered so that we can save the mother. This is basically to save the mother. So so this is a one attempt to save the mother if we can manage somehow by removing the compression of the major blood vessels. So we give her a tilt and we have to do the perimortem C-sections very fast. I've never done a perimortem C-section. I think Ashish and all might have done it, but I've
Yes,
never
we
done.
can only.
Thankfully, I've never had the chance to do one. But yeah, you take her up. You do the perimortem C-section wherever she is. You don't have to like prepare for the operation theater. Whether if she's in the casualty, you do it in the casualty. If she's in the ICU, do it in the ICU. Immediately paint, immediately clean, and give the with one incision, open the skin as
Single
well as the
incision.
uterus, deliver the baby, and then simultaneously the resuscitative processes have to continue.
Very rightly said by Dr. Nivedita ma'am. Thank you everyone. Now coming to our expert, and he will guide us about the collapse patient as well as his experience about the perimortem cesarean section in his whole lifetime. Over to Dr. Ashish sir. You need to unmute please.
I'll start with the second question first, because
Yes,
my obstetric career started with the perimortem cesarean section.
Oh my God.
42 years ago, exactly 42 years ago, I was in NRS Medical College as an intern that time. And I performed the first cesarean section of my life. And I was itching for doing a cesarean section. My seniors told me, here is a case you can do, because we cannot hand over our living baby to you. So here is it for you. But fortunately, the baby was alive. And I got a lot of applause in that during that period of time. Since then, I have done 4 cases rest of my life, but not every time that I was rewarded. But perimortem cesarean section, yes, must be done within 4 minutes. And there should not be any delay in doing and taking a heart to the OT table, etc., etc. No. Wherever the patient is, you just need a table and a scalpel and a Cortland. That's all. That's all the set that you need. So you give a vertical liberal incision and then take out the baby, hand it over to the pediatrician, and then suture the uterus. You may not suture also, doesn't matter really. And then come out of this thing. So perimortem cesarean section is the rule nowadays. And we have seen many cases where we improve prognosis not only for the baby, but also for the mother at times. Very recently in medical college, one case has been reported. The mother also survived. Now, the second point about the abruptio placenta I'd like to highlight is the coagulation. You know, the coagulation happens very early, and most of the times it is without any warning sign. So we should be very careful about the coagulation setting in both the revealed variety as well as the concealed variety. In concealed variety, because of consumptive coagulopathy, so we need to be very, very, liberal about administration of blood, and the coagulation mechanism has to be restored. Remember, the more delay you do in transfusing, more you are paving the way for DIC. So I think that part should be this thing. If you do an INR test that is useful, keep an INR between 1.2 but usually I have seen that most of the times the bedside clotting test is very, very useful. Just take a test tube and just tilt it and find out how much it is. So I think these are the tips that I can carry forward to the next generation, because these things are lacking these days. And this obstetric management in a case of collapse is really an emergency, and one should be prepared, and there should be adequate drill for all the conditions. And I'm very thankful to Kalyan, because he has put an array of cases, such nicely, thoughtfully devised cases that he has kept. I'm proud of you, Kalyan.
Thank you, sir, for your guidance. And you are a true academician who is guiding all the patients in medical college as well as private practice. Also, you are helping all the obstetrician to know what are the recent protocols, how you do about the VBAC, how to manage a patient with collapse. That is very important for the future generation, because the newer generation doesn't know all these complications because of the working in the multi-specialty hospitals. They have ready-made. Any patient of collapse comes, they just call the physician and anesthesiist and they take over, and not a gynecologist. But people like us who are working in a single specialty or maternity home, it's very important.
Yeah.
Your message is going to be helpful for practicing all of us. Thank you, our expert, Dr. Ashish Kumar Mukhopadhyay sir, who has guided us in such a good way. Thank you to Dr. Nivedita Datta madam. Thank you to Dr. Varuna madam.
Thank you so much. Thank you, sir.
N. Roy. Thank you to Dr. Pronomita Ghosh, Dr. Sindhu Bala madam, Dr. Rupam Singh madam, Dr. Varuna Verma and Dr. Kusum madam for all the inputs, and they are really good panelists, and they have guided me also in some cases. So it's going to be a really boon for our practice today. And I thank everyone who are involved in this webinar, that is Dr. Monica and Dr. Shatabdi, who are the guiding force, and they are real pillars behind this eco webinar. I am really thankful to them. Over to Dr. Monica Umbardhan for vote of thanks.
Thank you, sir.
Yes,
sir.
Ashish sir.
Because she's the person who called me first. But I couldn't piece of Shatabdi up to now.
Thank you, Kolyan sir. Thank you, Shatabdi and Monica. Ma'am. Yes, I will still the end.
Yes, Dr.
Very
Moshmi
nice
ma'am,
program.
thank you so much for being till last moment of this webinar. And we have really good audience for this webinar.
Yeah.
Thank you.
I have been
everyone.
associated with Monica since the days of Spy. Monica, you remember those days? We had a lot of programs together, and so much so, I'm so much in love with her that I have saved her name in my mobile as Monica, oh my darling.
Oh my God.
Sir,
Ashish, when will you change?
Sir, I have told this to Shatabdi, and the first lecture that I heard from you was maternal collapse.
Yeah.
And from that time, I am in awe of your academic skills, sir.
So I am very thankful to Kalyan, an excellent organizer, and kudos to you, and wish you all the very best in your election. I'm sure
Yeah,
you will,
Dr. Kalyan, all the best.
you will win hands down.
Yeah,
No
yeah,
problem
Dr.
about that.
Kalyan. Wishing you all the best.
Thank you, ma'am.
And Ashish sir, you are a very good expert on this.
But I'm XY. I'm not expert, I'm XY.
No, Dr. Kalyan, very good, because you took one talk and one panel and you gave a lot of time for both, which is, it was made it very interactive. So that is something which I appreciated, rather than, everybody trying to hurry through every talk and every lecture.
Yes,
And
ma'am.
all the faculties were wonderful.
Yes, ma'am, and it is only possible because of 3 OBGYN societies, Siliguri, Kolkata, and Bokaro.
Correct.
They are the real gem people who have been here till the last moment and answering all the questions in a really practical way. That is what is important, and audience is going to be benefited.
But I still cannot see Shatabdi.
এবার শতাব্দী কে ও মাই ডার্লিং করে সেভ করে দেবেন।
Sir, I'm there. I'm very much there listening to you all.
Yeah, you are audible but not visible.
Sir, right now audible is better. I will see you at AICOG in person.
Okay. He's keeping the best. He's keeping the best reserved for AICOG.
Yes, sir. Yes, absolutely.
Thank you,
Ashish
Asha
sir, you have
ma'am.
to sing the song. Ashish sir, you have to sing the song Monica, oh my darling in AICOG.
That will happen in private meetings, not in public like this.
Recording to be stopped. Recording to be stopped before.
Yes, we can stop
Thanks, Dr. Monica.
recording, ma'am, and we can hear a version of Sir's rendition of the song actually.